tell you where we're live. Ready?
That is me to me. He turned off the television.
Right. No, I've lost the meeting. Please come lost the meeting.
Okay, I guess we start now. Welcome to this session on
Tino, you've gone on to mute.
Session with Andy Locke and Claire Morden. My name is Tino Greif. I'm the Board Director of Training and Education for the ERC. And we have 6 very excellent presentations. These are the best of the best abstracts on education and implementation for this conference. And the session will go in this way that we have pre-recorded videos we will see, and after this there's the possibility to ask questions either from the facilitators or the audience. If you have a question, please type this in the system, either in Slido or directly. You can do this also on the web page. And with any further ado, I hand over to Claire, who will start with the first presenter.
Thank you very much, Tino. First presenter is Domagoj Damjanovic, who is going to be presenting a very interesting chat that I hope we can all learn for regarding the simulation and in situ simulation and eCPR. Go for it, Domagoj.
Extracorporeal cardiopulmonary resuscitation for refractory cardiac arrest in Germany. This was a nationwide survey conducted by the eCPR ECMO working group of the German Resuscitation Council. And hereby I would very much like to acknowledge all the authors listed here. From an ALS and conventional CPR viewpoint, the addition of eCPR markedly increases complexity of the whole scenario, as is illustrated in this image here. Looking at studies across nations and rescue systems, the integration of eCPR into these rescue systems is obviously subject to considerable variability in terms of logistics and organization, medical management, and education. The objectives of our study were to provide an overview of current eCPR practices in Germany. An online questionnaire was sent between January and May 2019 to 99 institutions in Germany. The return rate was 37, and 33 institutions actually do provide eCPR. The questionnaire consists of 51 items, and one leading question was, does the application of eCPR serve the overarching and leading paradigm of high-quality CPR, minimizing interruptions and low flow time, regardless of how complex the scenario gets? Regarding the results, looking at pro and contra criteria applied in real life, it is worth remembering how a typical list of criteria actually looks. And here is an example also applied in our center, and here you can find, for example, an age limit of 75 years. When looking at real-life results from the survey, we also find age limits. For example, when you ask participants below which age they would definitely like to go for eCPR, it could be 60 years. But when in the same center asked above which age they would rather not go for eCPR, the value could be 75 or 65 or just different from the first value. That means rather than one single cutoff, we will find a range and some kind of gray zone here. When looking at what information is actually considered most important at the time of decision making, respondents listed no flow time, witnessed or unwitnessed arrest, and age as the most important data points, whereas, astonishingly, ETCO2 was considered less important. With regards to simulation, any kind of simulation was applied only in 37.5%, and in situ simulation was applied even less frequently. As a conclusion, the survey confirms a high variability on an institutional and situational level regarding the ECPR application and integration into existing rescue systems. For example, patient selection and decision making often happen on an individual and case-by-case basis, and in real life, ranges and gray zones rather than single values are applied. The results could serve as a starting point for targeted improvements, which could begin with harmonizing definitions and several criteria. The process can be refined, but should always be aligned with the leading paradigms of CPR in general, which is, again, not interfering with the resuscitation measures and maintaining high-quality CPR and chest compressions. These results also have implications for providers not only of eCPR but also of conventional resuscitation. And to conclude, the seamless integration of eCPR into any rescue system and into any code is teamwork. Thank you, and I'll take your questions.
Thank you very much for that presentation, Domagoj. It was very, very interesting. First of all, I will take any questions off the, have we got any questions through on the streaming? No, Tino's shaking his head, I couldn't see any. So I've got a question for you, if that's okay.
Sure.
You specifically asked about the use of simulation and even in situ simulation in the eCPR centres. What do you think its use or role could be in eCPR programs?
Thank you for the question. The one thing, of course, is always task training. Like eCPR involves cannulation of huge vessels. You need to handle the equipment, and that means, of course, you will need simulation to do the task training for the eCPR providers. But what we also learned is it's not only about the cannulation, about those single tasks, and it's even not only about the machine, but it's rather about the process, because you have to integrate not only the eCPR providers and professionals and what they are doing on the groins, like poking the vessels and placing the cannulas, but at the same time, you have a code ongoing. That means you have an ALS team on the other side, and this whole group constitutes a new whole team. So it's basically made of two ad hoc teams who not necessarily always work together. And that means you have to, integrate those two processes into one without, and that's what basically the survey was about. And what I also tried to say is without interfering with what we know is good resuscitation. That means you should not prolong pauses, you should not prolong chest compression interruptions and everything, and you should not disturb the code by doing eCPR, but you want to help the patient, right? And that's what you actually can practice with simulation. And that also helps you improve the process in its whole. So you will find, like, how should communication work? How should roles be distributed between team members? What are the critical points? How do you integrate timeouts and everything? So basically, to give a short answer, simulation and in-situ simulation will serve for an improvement of the overall process.
You're muted, Claire.
Brilliant, thank you. Sorry, it's technology. I've got to get used to this. So I think there's one question over on from the panel on Slido. Tino, do you have it to hand?
Yeah, Don Marco, maybe this is a short answer. That's the question. Is there a curriculum for these simulation courses?
I mean, what we are doing, you mean what we are doing with simulation?
No, there's a question, is there a curriculum on these simulations? Is there a consensus? What should be taught?
It's not official yet, but we are working on one actually. And we are trying to establish exactly this, building on what we know from ALS providing courses and from those well-known and well-established curricula. We try to build on this and build something that could be as confirmed and with a good consensus like going on with this.
Okay, would be interesting to read this.
Working on it. We'll love to share.
I think one final question to do with the curriculum and things you've learned along the way. Obviously, yours specifically targets eCPR, your survey. What can you take that would be translatable or transferable to how ALS and CPR in general, for example?
Well, what we understand is, like many of you will face, lots of new technologies, lots of new advanced methods in resuscitation and life support. That means like ultrasound or mechanical CPR, like all those advanced things that go beyond what you are used from basic life support or from conventional advanced life support. And it's always the same issue that if you have new technology and advanced stuff and complicated stuff, that adds to complexity of the whole code. And if you add complexity, it again can disturb what you need, is good chest compressions. And so the issue is always how to integrate those complex things into the whole process, not to disturb the good code and the good resuscitation. And that needs a lot of training, that needs simulation, and that needs process and task alignment. And if you're aware of this, this is a very good basic concept to carry into the future of resuscitation, if you want it like that.
I'd like to thank you. For the sake of time, we have to go to the next speaker. It's my pleasure to introduce Niklas Breindal from Denmark, and we will go directly into your presentation.
My name is Niklas Breindal, and I will present our Danish randomized controlled trial where adult laypersons participating in ERC basic life support courses were randomized to receive teaching on how to recognize breathing patterns in cardiac arrest using the conventional lecture-based teaching method, a simulation-based teaching method, or a video-based teaching method available through the QR code, which you will find in the top right corner of the entire presentation. Agonal breaths are present in approximately 40% of victims in the first minutes of cardiac arrest. If responded to as a sign of cardiac arrest, studies like Bobro from 2008 find increased survival rates with and without bystander CPR, emphasizing the importance of early recognition. Yet, agonal breathing frequently delays recognition of cardiac arrest, time to start of TCPR, and time to first compressions, as shown in this study by Fukushima from 2017. However, teaching laypersons how to recognize breathing patterns is challenging, and Perkins from 2005 discovered that the ability to recognize agonal breathing among certified BLS instructors was only 61%. The development of more effective methods for teaching laypersons how to recognize agonal breathing thus has the potential to improve outcomes in patients with cardiac arrest initially presenting with agonal breathing. We hypothesized that video and simulation-based teaching methods would lead to improved recognition of breathing patterns compared to the conventional lecture-based method. The primary outcome was recognition of breathing patterns in 9 different videos of actors simulating normal breathing, no breathing, and agonal breathing, 3 of each. The secondary outcomes were the recognition of each breathing pattern, normal breathing, no breathing, and agonal breathing respectively. We analyzed outcomes using likelihood ratio tests and logistic regression models and present results as p-values and odds ratios with 95% confidence intervals. 153 participants were included in the analysis from February 2018 through May 2019. Recognition of breathing patterns regardless of type was statistically significantly different between the teaching methods. Compared to lecture-based teaching, both video and simulation-based teaching led to significantly more correct answers, as you can see. Video-based teaching was not statistically significantly different compared to simulation-based teaching. There was an overall statistically significant difference between the teaching methods regarding recognition of normal breathing, but unfortunately no significant differences for recognition of no breathing or agonal breathing. Maybe because our trial was only adequately powered for the primary outcome with 3 times as many answers as the secondary outcome. Our primary outcome was recognition of breathing patterns in all 9 videos. Our conclusion is that video and simulation-based teaching methods led to improved recognition of breathing patterns among adult laypersons participating in BLS courses compared to the conventional lecture-based teaching method. Video-based teaching is not dependent on instructor skills and does not require specific instructor training. It can serve to standardize and quality assure the teaching between various instructors and resuscitation councils worldwide, and it can be carried out in plenary. Furthermore, videos may be made available to participants, allowing them to revisit the material after the course, which potentially can increase retention. Thus, video-based teaching can be implemented in existing BLS courses without substantial increases in time requirements or costs. Thank you for listening, and please feel free to use our teaching video on agonal breathing using this QR code or the link in the bottom.
Okay, thanks for this very excellent presentation of a very nice study. Before we go into other comments, my first question, or maybe there are 2 questions in one. I didn't really get who were the participants of your study, and there's also a question in the chat asking how was the agonal breathing taught online? This was a video made of mannequins, or what was it? Could you explain this a little bit?
Yes, of course. So first of all, agonal breathing could be taught online using the video. That must be obvious after this presentation. And the participants in our trial were 3 types of laypersons, Danish laypersons. They were university students, military conscripts, and elderly retirees. So we excluded all healthcare professionals and chose these 3 different types of adult laypersons to get this kind of broader representation of Danish laypersons. And this also made us available or able to stratify the study among these 3 types of laypersons in order to minimize the differences between each group.
Okay. Did I understand this correctly? You had a training, a lecture-based, video, and simulation, and then you tested all of them on a video.
Yes, that's true.
So my question is, maybe this was only a testing effect, because if I'm trained in a video and I see the video, great. If I was trained in a different modality and then I'm tested in a different, could you say a little bit, go into this?
Yes, of course. So we tried to make the teaching video and the testing video very different in terms of choosing different actors, first of all, and various kinds of presentations of agonal breathing. But of course, this is one of the limitations to the study, that breathing assessment in reality as well may be much more complex due to higher stress levels because of emotional attachment to the victim, or continuous disturbances from like various sensory input and input from team members and other bystanders as well, or relatives. So this is only a teaching effect that we found in this study.
Mm-hmm. Okay, I think we have to go to the next presentation, and Andy Locke will introduce the next speaker.
Thank you very much, Tino. It's my absolute pleasure to introduce to you our next speaker, who is Gabor Fritus from Budapest, who I first had the pleasure of meeting and teaching with way back in 2004. So an old friend and an old face from the past, but I'm so looking forward to your presentation, Gabor.
Dear Chair, dear colleagues, as we are working on improving the fidelity of simulation, now it is my privilege to share our first experiences on using eye tracking glasses to measure fidelity of various educational methodologies, the traditional cardiac arrest scenario and a novel one. On the left, in the traditional SBME setting, the team leader has to share his attention among the instructor and the team and the patient. On the right, in the drama model, the instructor is removed from the situation. He supports the team leader as if he was in his mind, as a so-called inner voice. He can express the team leader's feelings, thoughts, can provide information, everything in first person singular. In our research, we compare the students' gaze pattern to experts' ALS providers' gaze pattern. Students are divided into two groups by two different teaching methods, the traditional SBME and the drama SBME. Students' gaze pattern are measured during the cardiac arrest scenario teaching situations. The question is that which educational method resembles more to the experts group. We made measurements by eye tracking glasses and with additional tests. Here we can see the eye tracking glasses, which can identify the direction of gaze by near infrared technology. Applying and the application of these eye tracking technology in this field is something new. They use it in market research or in human computing interactions and so on. On the left, you can see measurements of the SBME method. Here is the team leader with glasses on in the middle. And here we can see the instructor who is giving an inner voice to one of the team members. And on the right, you can see the same situation synchronously from the team leader's eye camera. The red dot represents the actual gaze focus. We had the preconception that fidelity can be measured by an uncontrollable component of behavior. So we measured the gaze pattern by eye tracking glasses, as we would like to know which educational method is closer to the expert's reference group. We have already promising preliminary results from NASA task load tests. This shows that significant difference there is a significant difference between the two educational methods. Data analysis is under process. Here are the video codes with which we analyze how many times the team leader looks, for example, on the patient, on team members, or on equipments, because we would like to know how the team leader is present in the situation. As for closure, we are comparing various educational methods using eye tracking glasses because we would like to improve fidelity of simulation. As an acknowledgement, I would like to say thank you for all the colleagues who took part in the study, and I would also like to thank you for your kind attention.
Fantastic, excellent presentation, Gabor. We already have one question that's come in online from Robin Davis from the UK. Thank you for an interesting talk. Does eye tracking measurement provide value other than a test or measure of situational awareness? So I guess this is a question as to why you've used eye tracking.
Well, it's a very good idea, and thank you very much for that. We haven't tested it yet for situational awareness, but this is a good idea, and probably we'll do something with it because it can. Now we had only the making comparison about the experts' gaze pattern and the students, the candidates' gaze pattern, who is in the team leader's role.
So I guess obviously there's resource needed for this sort of approach.
Actually, as for human resources, if we take that, okay, this was about two things. What was new? It was the eye tracking glasses, the usage of eye tracking glasses. It needs technology and resources, of course. And we had a collaboration with Budapest Science University, or Technical University. And on the other hand, the drama-based medical education doesn't really need an extra resource, because we worked with full ALS providers and full ALS instructors, and they needed some 1 or 2 hours to get familiar with this DSBMA method, the drama and simulation-based medical education. And we can support or we can provide some supplementary device on methodology. And it means that for us, we think that the same amount of time needed for getting a full instructor in dramatic, to be a dramatic instructor.
It's fascinating work, Gabor, and certainly look forward to hearing future research around it as well. Thank you very much for your presentation today.
It was my privilege to be here. Thank you.
I'm going to move now to Claire, who's going to introduce the next speaker.
Thank you very much, Andy. It was a fascinating chat. And next up, we have Roma Calaria, who's chatting about prognostication post-arrest.
Good evening, everyone. I'm here to present my audit findings on post-cardiac arrest management. So the main purpose of our audit was to assess the post-cardiac arrest management, including the neurological prognostication process for patients admitted to Birmingham City and Sandwell intensive care units in the year 2018. As per the European Research Council guidelines, there has been an emphasis on using a more delayed multimodal prognostication strategy. What this means is that prognostication process should only be attempted 72 hours post-ROSC, and a combination of more than 2 aids should at least be used. prolonged observation is recommended if the outcome is uncertain, and there is an emphasis on allowing adequate time for the sedative agents to be cleared. So in the year 2018, a total of 88 patients were admitted to our intensive care units. Out of them, we studied the cohort which were being ventilated at the end of 72 hours. There were a total of 33 such patients. Out of them, 7 patients are alive, 26 patients died, out of which 24 died on intensive care unit and 2 died on the ward. Targeted temperature management, which was used in 87% of our patients. As per the guidelines, temperature of less than 36 degrees Celsius, which could either be 32 to 34 or less than 36 degrees Celsius, is recommended in the initial 24 hours post-ROSC, and in 24 to 72 hours post-ROSC, a temperature of less than 37.5 degrees Celsius is recommended. There is increasing evidence to say that not only hypoxemia, but hyperoxemia can lead to worse neurological outcomes. We assessed the oxygen saturations of our patients, and overall about 25% patients were being over-oxygenated and had SATs of more than 98%. We looked at the sedation agents being used in our study, and overall about 15% of patients had longer acting sedation agents being used. We looked at the GCS motor score at the end of 72 hours for our patients, and we studied the subgroup which had a GCS motor score of 1 or 2 in further detail. GCS motor score of 1 or 2 has got a high sensitivity for prediction of poor outcome, so it is useful as a screening tool. In this subgroup further, about 40% patients had a repeat electroencephalogram done, about 80% had CT brain done, 60% patients had clinical assessment of myoclonus done, and about 16% patients had somatosensory evoked potentials done in the form of prognostication aids. However, only about 40% patients had more than 2 unfavorable features which would suggest a poor outcome. When we look at the overall outcomes in this subgroup, the mortality was 100%. For patients who had more than 2 unfavorable features, the mortality was 86%, which was anticipated from their prognostication aids. But even in those patients who had less than 2 unfavorable features, the ICU mortality was 100%. Now, the most common cause of death after 72 hours in these patients is withdrawal of life-sustaining treatment. This leads us to think whether there was premature withdrawal of life-sustaining treatment in any of these patients, and this is being looked at in another audit. So to conclude, targeted temperature management was widely used in our patients, and we were very effective in preventing rebound hypothermia. Over-oxygenation is common and easily avoidable. It probably needs more education and awareness amongst the nursing staff as well. The use of longer-acting sedation agents could possibly be reduced, and there were several examples which would suggest inadequate multimodal neurological prognostication in our study. Thank you. Any questions?
So thank you very much for that talk. It was actually, I found it very, very interesting. There's quite a bit on neuroprognostication at this conference. It's interesting you talk about the modalities, because I know it was mentioned earlier in the update to the guidelines about having 2 factors to predict outcome when you're prognosticating. One of my questions comes, you mentioned about clinical examination and myoclonus. Are there any other clinical signs that you used in this that would guide you in your prognostication process?
Yeah, thanks Claire for the question. So in addition to the clinical assessment of status myoclonus, clinical examination can also include assessment of bilateral pupillary light reflexes and assessment of corneal reflex. And how they are important is that they have got a very less false positive rate and a very high specificity. So they can be used as prognostication aids as well.
And another question I've got, it was quite interesting earlier to hear about NSE, neuron-specific enolase. It's not something I've come across in the UK, and I would just be interested also as a group as to how much it's used and if it is a cost factor why we don't use it in the UK. I'm not sure if anyone can enlighten me on this in prognostication.
Thanks, Claire. Yeah, so we don't use biochemical markers in our trust as well. But after this audit, I know that there was some consideration being given to the same. But yes, the advantage of biomarkers is that they are independent of the residual effects of neuromuscular blockers and the sedation agents. And hence they can be quite useful even in patients in whom sedative agents have not been cleared and have had to be used for clinical reasons like for suppression of status epilepticus. So it would be interesting to, although there is no specific threshold accepted for neuron-specific enolase, so that's the main problem. It needs a specific number at which we can say this is the threshold at which we can predict a poor outcome.
Thank you very much. Out of interest, opening to the rest of the floor and everyone else here, does anyone else routinely use biochemical markers in their practice in other countries? There's silence, so I take that as a no. Okay, I will hand over now to Andy, who's going to introduce the next speaker.
Thank you very much, Claire. As an emergency physician, no, I don't use biochemical markers because I usually don't have the patients in my department for long enough to do that. It's my absolute delight now to introduce Paulina Kaluza, who's from Witten, which is a beautiful university town just to the southwest of Dortmund in Germany. And really looking forward to hearing your talk, Paulina.
Good evening, everyone. My name is Paulina Kaluza, and I'm a medical student at Witten University in Germany. It is a pleasure for me to present the results of my doctoral thesis done at the anesthesia department in Bern, Switzerland. Over the last decade, it became clear that not only scientific knowledge and technical skills, but also human factors are important for ensuring high quality in the management of sudden cardiac arrest. With the 2015 ERC guidelines, life support courses should not only focus on conveying technical skills, but also on teaching human factors or non-technical skills. These human factors include all elements that are related to cognitive, personal, and social skills of individuals applied to improve performance during resuscitation. Especially important in advanced life support is team leadership and decision-making, resulting in proper team performance, communication, and situational awareness between all, leading to a reasonable resource management. On the other hand, technical skills summarize the knowledge and the skills about, for example, algorithms, drugs and dosage, and reversible cardiac arrest causes. The current assessment after ERC Advanced Life Support courses does not test these human factors. So, our study was interested in the assessment of these human factors and the perception of the different testing methods between the ERC and the AHA approach to the final summative assessment. The goal of the study was to evaluate how students and instructors of ERC Advanced Life Support courses perceived if the assessment covered the course content on human factors. Participants were 5th and 6th year medical students of the University of Bern who participated in ERC Advanced Life Support courses and were randomly divided into 2 groups for their final practical assessment. One method was the ERC assessment and the other method was the AHA test. I will give you a short description on how these both methods work. In both of them, the tested person has to lead through a standardized cardiac arrest simulation test. In the ERC assessment, the team is represented by only one instructor who behaves like a multifunctional team member and executes all resuscitation actions the tested team leader mandates. So most of the time he can only pretend to perform resuscitation actions in a team. In the AHA assessment, the tested person has to lead fellow participants forming the cardiac arrest team. Team members are told only to do what the team leader tells them to do, but nothing else. So the team leader performance can be assessed as much as possible. In our focus group interviews participated 27 students and 5 instructors. 14 students experienced the ERC method and 13 students the AHA method. All instructors had experience with both methods. The transcripts of the interviews were analyzed by 2 independent researchers with help of the program MaxQDA 2018. The interpretations were discussed in the study group until consensus was reached. Now I will come to the results. My thesis revealed that knowledge of the algorithms, drugs and dosage and CPR quality parameters, so basically technical skills, are assessed by both assessment methods. Whereas only the AHA assessment was able to test human factors, especially communication and team membership. Therefore, we conclude that course participants and instructors perceived the summative group assessment was able to assess the learned resuscitation competences and the human factors taught in life support courses. I'd like to thank my co-workers and you for your attention.
Thank you very much for that, Paulina. A fascinating topic. It's one that I personally have a research interest as well in the educational delivery of life support courses. And I think you've raised something that we, within the ERC, we have debated over many years. But I'm guessing there are some challenges to such an approach as well, of getting a sort of group assessment at the end of a course. What sort of challenges can you see that we would need to face?
Well, thank you for the question. Well, of course, if you assess a person in a group assessment, the team leader might depend on the group performance. So if the group is quite alert and quite skilled at using CPR techniques, the leader might profit from that. So that could conclude a sort of bias by assessing the team leader. And of course, the group assessment might take longer than the other ones. So that would also might increase costs for those assessments.
Yeah, and I think that's what I've struggled with over the years, and with this as a concept, because I think you're right, we do need to assess and sort of look at the non-technical skills a lot more than we currently do. But that sort of dynamic of having potentially disruptive elements that are out of our control could be a bit of a challenge. So is there an argument therefore for maybe building it into more continual assessment throughout the course as opposed to a summative assessment?
Sorry, I didn't get the
Is there an argument for maybe assessing non-technical skills continuously over the course rather than as a summative assessment?
Yes, thank you. Well, we've talked about that, of course, as well. And we decided that the assessment at the end of the course is better, because then you must ensure that you always pay attention and that you always get the things the students say or perform. And this would be quite of a work too. And it might not be fair either, because some of the students might have earlier experiences or some other knowledge. So that wouldn't be fair to assess right from the beginning.
Okay, yeah, that's a very valid argument, and certainly for those of us involved in course design, what we teach is what we test. So the flip side of that is that what we test, we need to teach. So do you think we need to improve the way we teach non-technical skills on ALS courses?
Well, the course I have experienced was quite good. And I think that's also what the students feedbacked, that actually in the scenarios within the course, they were quite satisfied by that. They became always feedback, and they did know after that where their mistakes were. So they were quite a bit disappointed from the assessment at the end, because then they had to adapt and learn a new form for this participation. Yes, so I think the courses do quite well on that.
Excellent. Well, thank you very much for your research in this, and I look forward to seeing the rest of the research from your doctoral thesis. I think this is a vital bit of educational research that we do need out there, and thank you very much for your presentation.
Thank you, Andrew.
I'm going to hand back to Tino now.
Okay, our last presenter is Balint Banfev, also from Hungary, and he will bring us a little bit about Kids Save Lives and how to teach children.
Hello, welcome everybody. First of all, thank you for the opportunity to being here and holding my presentation. My name is Balint Banfai and I am from Hungary, from the University of Pécs Faculty of Health Sciences. And in my presentation, I would like to speak about our results in the topic teaching resuscitation for primary school children with different methods, with special regard to video-based method. We do not have any conflict of interest. It is well known that sudden cardiac arrest is a leading cause of death worldwide. In Hungary, approximately 25,000 people die every year. And in countries with high quality resuscitation training, outcomes are more better. So one of the best solutions can be starting resuscitation teaching in childhood. This is the reason why we connected also to the Kids Save Lives project. In our study, our aim was to measure the effectiveness of 3 different resuscitation teaching methods. In the frontal group, children went through conventional or traditional training. It was 45 minutes, theoretical part and hands-on training. The instructor was a paramedic. In the video group, there was no instructor. It was available a self-made video for the children. And in the phantom group, it was available the previously mentioned video and the self-made mannequin. The instructor was an own teacher of the children. In the pictures, you can see some parts and moments from our video. The actor of this video was a primary school girl, and she was 12 years old. Participants was between 10 and 15 years old, and we collected participants from 2 different primary schools. Knowledge and skills were measured before the training and 1 and 4 months after the training. Data collection was made by a self-filling questionnaire. It was the theoretical part, and a checklist based on a simulated situation on an AMBU CPR mannequin. That was the practical part. And in this picture, you can see our self-made mannequin. It was good for measuring and practicing the chest compression, but it was unable to practice the ventilation. In our study, the children's performance improved in every group after training when we compared with the baseline results. Participants in the frontal group performed the highest scores compared with the video and the phantom group. And when we compared the video and the phantom group, there was no significant difference between these two groups. The quality of chest compressions was the best in the phantom group, maybe because of the continuous possibility to practice with the self-made mannequin. In addition, children with higher age than 12 and with higher body weight than 50 kilograms performed deeper chest compressions. And the children's self-efficacy improved in every group and remained high after 1 and 4 months also. In conclusion, in our study, the best effectiveness was the conventional training, so the frontal group. However, the video-based method can be also effective, mainly for improving the theoretical knowledge and the self-efficacy. Moreover, in these COVID times, we need to improve the quality and use of distant learning methods, because this current situation can show that sometimes personal training methods are not available or not safe, and we need to follow the way of some alternative methods, because we cannot and we should not stop resuscitation training. Thank you for your kind attention.
Very nice study. This is interesting because we know from a lot of other studies and that video mannequins perform quite good. And now you present a study where the traditional teaching is better. How do you explain this?
Thank you for the question. And yes, it's interesting. First, I can say that in Hungary, in the Kids Stabilized in Hungary project, we have not a lot of experiences, but based on national results, we can see that yes, the video-based or video-supported method can be good. And I think in our study, the reason can be why the frontal group, so the conventional method was the best. Then the key point can be the instructor. So there was a paramedic who was experienced in first aid and resuscitation teaching. So it was the possibility to giving feedback immediately in the practice. Or for example, if there was any question from the children, he could answer immediately. And it is very important. And if we compare with our other two groups, the video group or the phantom group, the children's own teacher could not answer this question because he or she was not experienced in teaching resuscitation. And in the video group, there was no instructor. So it was able to improve skills and the self-efficacy, but there was no possibility to practice. But this is very important.
But on the other hand, if I would be a patient, I would like to have a kid who is doing proper chest compression. And you said the kids in the mannequin or in the self-made, they were the best in chest compression. But this is maybe the most important. So yes. Where should we go?
Yes, in this case, so we had only this one, so this is prototype, but later we can make it, I think, wider. And when we combine the video-based and the self-instruction kit, it can be, I think, the same effect than maybe in a personal training with a good experienced instructor. So we, as I said, we had not so high experiences in this topic, but we would like to follow this. And yes, the possibility can be then they had to and they could practice with this self-made mannequin in the meantime, but in the other groups there was no the possibility for the practicing only one time. So yes, I think we need to continue in the future.
There's a question in the chat about the age group. So you had children younger than 12 and over 12. There's still this kind of rule, wherever this comes from, children should be trained from the age of 12 on. What is how do you see this age limit?
I think then, so this 12 years age group was based on like the international Kids Save Lives, at least from the age of 12 years. And we had some other previous studies, and we could see then approximately from the age of 10, 11 or 12, children can be very similar like adult people. And in our programs, we go to the kindergarten. So it means it's approximately 5 and 6 years old children. And these are other methods, for example, the teddy bear of the children, or maybe a ball or any other self-made mannequins. So I think they can teach the methods, and not so seriously like in an older age, but if there is a sensitization, I think. So if they start to teach about first aid in the kindergarten, and we can repeat this knowledge every year, we have the chance to have a nation with a very good quality of CPR.
So very interesting to see what's then the final result of your studies. We are coming to an end of these sessions. Maybe Andy and Claire, some last words. What did we as a facilitator learn out of this session?
I think this has been a fantastic session. I think we've seen some really good research that is in evolution, some projects where there's still more research to be either done or to be published, and it's really exciting. Education is often seen as the poor relation, but I think it's actually the most interesting research topic. And so thank you very much, guys, and keep going with more and more research.
And I would just say it was a fascinating topic to listen to everyone's research that is ongoing. I, nowhere near on the level of Andy, is very interested in CPR teaching. And Balint, what I think is very interesting is I actually have been doing teaching at primary school, which we call in England younger than 11. So from 7 to 11. And I think, as you said, it's getting them sort of having it embedded in them by the time that they're a bit older. So you're just building on those skills. And I think it was valuable research you've done. So it's fascinating. And everyone's talks I thought were really, really good. So look forward to hearing more.
I only want to conclude that if you don't know, Resuscitation made a new journal which is called Resuscitation Plus. I have to say I have a conflict of interest. I'm, like Andy, one of the editors. And this journal specifically is looking for educational stuff, implementation stuff. So this is an open new journal for your publication. So if you think your studies are on the level to get to the audience, to be disseminated, think on Resuscitation Plus for publication. We hear I like this all this Kids Save Life, but on the other hand, don't forget to teach all the medical students and all the other students at the university. I think still it's a shame that students at universities have a very, very poor knowledge and skills on even BLS. So this is a major task, not only the kids, also the students. And with this, we are 1 minute to the hour. Really great time management by all of you. Thank you, and keep on doing high-stake research. Thank you, and bye.